I'm going to follow Renee's lead and speak to you over here. I think it'll be easier to see you on the slides. Can everybody hear me okay? All right. So one thing that I've actually committed to start doing is noting the airprint of each talk that I give. There's a sociologist at the University of Washington who recently wrote a somewhat scathing editorial about jet-setting academics and their carbon footprints. And I have to say I agree. In recent years, I have dramatically reduced the number of talks that I give, and I feel guilty when I go out and do other ones. And sometimes you have to do them. I feel like this was an important event. I wanted to come, and so I did. But I burned a lot of carbon on the way. This was 1 metric ton of CO2 round trip from Seattle to Indianapolis. That's about 1/20th of the average American household carbon budget. Individual budget, not household budget. I had colleagues who do global health work related to climate change, and I shudder to think what their footprints are. Part of cleaning our house, I think, is actually looking at issues like this and having what are probably some tough conversations, because we've got ways we fund conferences, we've got ways we build academic reputations, we've got perks that come with being in our positions, and they all go back to carbon. And we need to be more open and transparent about that. So that's how much this all costs from a carbon standpoint. I wish I could tell you exactly what the harms were, but that's potentially for another day. So we all are convinced or committed to evidence-based practice. And I put up here a diagram that outlines what evidence-based practice is. I think we often think of it as application of best research evidence, but in fact it's not only that. It's bringing that evidence to bear on a conversation that you have with your patient about what they want, and then bring in your own expertise and your experience about something and working together to forge a decision. And I think we need to take the same approach with climate change, and we need to push for research that helps us take an evidence-based approach to the roles that we have and the decisions we have to make with our patients. So it comes down to a set of questions. Who will be affected? What are the decisions we're going to be making with the people we're making decisions with, patients and otherwise? What evidence do we have? And what evidence do we need? And then, crucially, how do we package it and present it so that people understand it and are able to use it and carry it forward? Because this is a long-haul challenge. This is not a short-term issue. I hope that somewhere on here you see something that roughly mirrors your take on your work and why you're in medicine. Maybe you're connected to a particular place. That could be domestically or globally. Maybe you like a particular kind of disease pathway. You like particulates. You like infectious disease, vector-borne zoonotic disease. Perhaps you have a different focus, like toxicology or pre-hospital care. Or perhaps you think of yourself as in a particular role related to your work, whether you are an administrator or a data analyst principally, or an educator. I would argue that there are points of entry for all of these things related to climate and health, and that there's research to be done in each of these areas that is worth exploring. Because there's a dizzying array of questions to answer. And you've heard a lot of them today in this session. You've heard about how different impacts are going to affect different places and at different times. You have heard that there are going to be lots of different interactions. There are going to be disasters on a local scale and perhaps regional and national level scales eventually, that we're going to be responsible for taking leadership in. But what are people actually going to need from us? If you're trying to train a resident to deal with it, what are they going to need? And how does climate change what they would be able, what patients are going to need from them going forward? In some cases, it won't. You're going to be fully trained to deal with whatever the problem is. Climate change is just the context driving it forward. There's one more social determinant on top. But in other settings, there are actually climate-specific issues that you need to be able to discuss. You brought up the point of emergence. At what point, and it's not necessarily what level of carbon dioxide in the atmosphere, but when are particular natural hazards going to emerge? And how do we advise communities about that? Can we think about how these things are going to constrain our usual practice, and then how do we navigate those constraints more effectively? How do we think about training our medical students and residents? And what is our role, not just in terms of mitigation and greenhouse gas emissions in our hospital, but overall in the structure of the health system? Because it gets back to these social determinants of health. A lot of these disasters disrupt our ability to provide care effectively at a system-wide level. And we as emergency physicians are more aware of that probably than anyone else. Climate change challenges this. What do we tell people? What body of research do we rely on to answer these questions? And then how do we work with these other colleagues? And I'm not just talking about other colleagues in medicine, I'm talking across the board, climate scientists, et cetera. How do we work well with them so they understand what we do and we understand what they do and we can communicate about all our needs? So lots and lots of questions, and they are all, to some degree, amenable to research. This is a model of the 10 essential public health services. And of course, medicine is just a failed branch of public health. We focus on tertiary prevention. We are much better compensated and resourced than the rest of public health. But we're part of a larger effort. And research sits at the core of it. We mostly do diagnosis and do some care provision and some education. But there are lots of other ways in which we intersect with our public health role and provide essential public health services. One of the people that, if you're interested in this field, Tony McMichael, who's an Australian physician, he has passed away, but he did some really interesting pioneering work around climate and health. And he outlined 3 challenges for us from an epidemiological standpoint. He said we need to retrospectively characterize climate and health relationships. We need to enhance our surveillance of current health problems so that we're able to see when we're actually starting to have some problems related to climate change. And we need to develop scenario-based projections of future health outcomes. And I would argue that we have done this for the most part. Not fully, but we have quite a comprehensive catalog of these relationships now. We're doing an okay job of surveillance to detect current climate and health impacts, but it's not outstanding. We have done an okay job of this. This we can do pretty easily, actually, once we have done this. It's just a matter of money and expertise. The thing we haven't done, and I added this, he didn't put this in there, he wrote it years ago, is we actually need to be thinking a lot about adaptation. So how are we going to prepare and respond? And what do we do, how do we identify effective adaptations for what's coming ahead? So for those of you who are trained in evidence-based medicine, you'll see a familiar set of categories here. There are basically 4 domains of evidence that we tend to use. One is around harms, which is adverse impacts associated with a particular exposure. One relates to diagnosis. So how do you diagnose something and how well do your diagnostic tests perform, how do you interpret that, et cetera. One is related to prognosis. So somebody comes in, you give them a new diagnosis of cancer, what do you tell them about their survival, et cetera? And that comes from a prognostic set of studies. And then there's therapy, of course. So if we choose drug A over drug B, for combination 1 over combination 2, how do we make those decisions and why? And they all come with different kinds of metrics and study designs and other things. And I would argue that we have invested almost exclusively in this area with climate and health. That we have not really thought creatively about these other needs. Which is too bad, because in fact this is really actually where a lot of the action is going forward from my point of view. So I hope that we can start a conversation today about other ways to think about developing the evidence base that diverges from this focus on harms. Because the evidence is out there. Not everyone is convinced of the evidence, but I don't think we necessarily need tons more study of the harms of particulate air pollution and how climate change may modify that association. What we need is to know what's the best way to reduce at scale quickly so we get 5,000 hospitals in the country reducing their particulate air emissions and documenting those health impacts. That would be a study worth doing. In the climate literature, this is a graph from the International Government, or the Intergovernmental Panel on Climate Change, a special report on disasters that I was part of. And that group brings together a bunch of different disciplines. And the social scientists focus on thinking about impacts using a vulnerability and thresholds model. Whereas the climate scientists, of course, think about climate impacts and exposures. And they're both relevant, they're both valid, but they actually can lead you to pretty different outcomes when you're thinking about health impacts. And the social scientists say, in fields where you actually have a lot of unmanaged vulnerability at present, it's much better to think about social determinants of health and how climate change feeds into an already vulnerable system, rather than just to think about, okay, well, it's getting a little hotter. How is that heat going to impact disease burden? It's not to say that one is right, one is wrong, but there are different ways of approaching the problem, and I think it's important when you think about climate change and health research to actually acknowledge that there are lots of different ways to try and answer these questions, and some of them start with looking at vulnerable communities, which I know is a theme that you've heard already today. Another point I wanted to make is that this is fundamentally interdisciplinary work. We cannot generally go this alone. There's an exposure element that requires climate scientists, or at least understanding of those things. There's a whole geospatial epidemiology and mapping approach that a lot of us don't have those skills. There's systems modeling. There's a lot of complex system science involved in these, and we sort of intuitively get this, but often most of us don't have those skill sets. And then, of course, there's the knowledge translation, which more and more of us do have in medicine. And this is only the approach to one set of problems. There are a whole bunch of other problems that require other disciplines. Some of the work that I've done is around heat early warning systems and developing early warning systems and applying them in low-resource settings. And that work also requires a lot of synthesis and a lot of interdisciplinarity. You have to have environmental health expertise to look at the exposure and the response functions and identify thresholds for acting. You have to then bring in scientists, meteorologists, and climatologists who can help you develop appropriate and skilled weather forecasts. And then you have to think about communication. And you have to be able to tell people what will happen, what is the prognostic evidence around exposure to temperatures of a certain level. And then how do you actually intervene, particularly in a low-resource setting. If you're in India and only 3% of the population has air conditioning, and the temperature is going to be 46 degrees Celsius today, what do? You can't just tell them to go to a local cooling center, because there is none. So there's you're winging it, and we're comfortable winging it a lot of times, because we're in the ED, and that's kind of what we do. But I'm sure everybody has been at the place where you're starting to wing a little too much, and you're on wing and a prayer. You don't have the evidence to actually help you with the situation you're in. And we can remedy that through research going forward. I am not going to lie, this is a tough road to hoe. It's politicized. There's no funding for it. There is a real emphasis on harms in the environmental community and not on therapy. This is not what they want to be doing. They don't understand how to do it. They're not trained to do it. And most of this, the money for this, goes through environmental health right now. The money that is available. It's a big, complicated field. And even if you know a lot, it's, I think, hard to strike the right balance between getting depth in a particular area and being broadly capable. And then because of the interdisciplinarity, it's really helpful to be in a big institution that does a lot of things well. If you're not, then you have to find partners elsewhere, which is certainly not a problem, but it adds an extra layer of complexity and transactional cost to your research effort. And then lastly, data can be hard to get. This is becoming easier and easier, but still, this is a challenge. When you want to look at 30 years of health data and you want actual exposure information, good luck. It is hard to find, and when you do find it, it's often expensive. So having good partners with good health data is key. That said, it's a young field, and I know it's going to be very important going forward. I mean, it's essentially certain to grow. Our emissions trajectory guarantees it. And Stu and I were talking earlier, he's fairly sanguine about things. I, frankly, am a little bit pessimistic about things. I think by mid-century, we're going to be dealing with some really, really tough challenges. And I think they're going to hit us squarely in the nose in the ED. But your expertise is really going to be needed. And it's an excellent field for generalists, which is what we are. So there's really no way to go wrong if you want to engage in climate and health research. There are lots of questions to answer and lots of ways forward. So I'm looking forward to more conversations that we can hear from our colleagues about what they're interested in studying. So thank you.